In this third part of the three presentations, I'm going to deal with the management of fibromyalgia, hopefully illustrated by the previous two parts. So in management, the communication with the patient is extremely important. Hence, that communication starts at the time of history taking, so you get a complete picture of what's going on, and the patient is reassured that you have understood all of the problems. Understand yourself that fibromyalgia is a complex and heterogeneous condition, and so it needs inquiry into all of the systems. The patient also needs to know that that's where you're looking and that's what you found. Understand that there is abnormal pain processing, but that other features also indicate probably abnormalities in other sensory processing. For management, one needs a multidisciplinary approach where possible and a multimodal approach. And primary care is probably the best pivot within which to manage fibromyalgia. For the patient, they need coping skills for this chronic illness. They need to understand it in order to take away emotions that might heighten the problems. Some cognitive behavioral therapy is helpful. Counseling, particularly for preceding events that may have partial or complete influence on the disease. So bereavements, relationship problems, other issues need to be helped, and sometimes helped by counseling. The patients need support not only from their medical and paramedical people, but also within their own families. You must aim at normalizing the patient's life as much as possible, getting them to continue to function and to work as much as possible. Set targets. So the doctor needs to set targets for activity. Activity like, first of all, recreational activity like walking or sport. Also activity within the person's environment or function. So a certain amount of housework or gardening or that sort of thing. Have it individual to the patient. Try to keep the patient working and encourage them to continue working, even if you have to alter some of the work environment or some of the work practices or some of the work hours. And get the patient to rest because they are fatigued, but to rest in a prescribed way. So rest for half-hour sessions once or twice a day in a prescribed way, so that they're not resting to get rid of fatigue that is not going to go in the short term. And again, the patient's previous experience of fatigue is, well, if I have a good rest, I'll feel better and I'll be fine. But that doesn't necessarily happen with fibromyalgia. So they may need rest periods, but not all the time, and not rest until they're well, because that is counterproductive. Monitor what is measurable. And in that scenario, the fibromyalgia impact questionnaire is very useful, and I'll refer to that and show you an example of that at the end of this presentation. If you're going to introduce medication, try and limit it to a month and then review, so the patient doesn't creep onto one medicine after a time, one medicine after the other, with failures of one and addition of another and then another and then another. Manage the medicines very actively and stop them if they're not being helpful. Use definite advice with regard to diet. Don't be too generalized as regards, well, you should try and have a healthy diet. Tell the patient what you think is a healthy diet. Focus on what is possible. So don't ask the patient to do things that are unrealistic. See what they can do. And if their walking tolerance is only 10 minutes, well, start off by asking them to walk 10 minutes 3 times a day. Don't ask them to push it to 20 minutes and do that twice a day. Walk within their capacity and do it repeatedly. That way you'll build up function and build up activity and build up also targets that they can reach. And in reaching targets, that itself is a positive influence. Focus on function. Focus on what can be done. And ask what has been done. What way have targets been reached? Have a reasonably optimistic, realistic attitude to the management. For the patient, you need to explain that they have an abnormality in the transmission of sensations, particularly pain. It's central pain. It's different to what their previously experienced pain. But sensations from other organs also seem to be transmitted and interpreted in a different way to previously. And so understanding those abnormalities within the transmission of sensations itself helps the patients to deal with their symptoms in a way that's different to symptoms in their pre-morbid life, as it were. Equally, sensations of abnormal sensations with regard to mood and fatigue are also part of the problem. So the need to reset thresholds for these abnormal sensations, so they're given less prominence and less weight. So the patients need understanding. They need to change their thinking with regard to some of their symptoms. They need to act and behave as near normal as possible, because all that begins to put normal sensations from normal activities into their milieu, and that hopefully will suppress some abnormal sensations. So this additional sensory input of exercise, activity, is going to have a positive influence on their other symptoms. Sometimes drugs help. They may suppress some of the symptoms or reduce some of the symptoms, and that should be sufficient to allow more normal activity. So another way of explaining to patients is that they have a software problem. It's not a hardware problem, and that's the previous experience of pain is as a hardware problem signified by pain. Now it's a software problem, and pain is the problem. That the thresholds for their thermostat, for their various sensations are super sensitive. They're reduced, and they need to be reset, and they need to be reset by inputting normal sensations as much as possible. Management with drugs. This I have taken from the EULAR recommendations on the management of fibromyalgia. And the drugs used are some available in some European countries, some are not available in some of the countries. Tramadol, simple analgesics such as paracetamol and weak opioids are useful for pain. But again, know that we're expecting those drugs to reduce the severity of the pain, to take the edge off the pain. They won't abolish it. It's fairly strongly advised not to get into corticosteroids and strong opioids because they're not effective, and they will lead to that therapeutic creep I talked about earlier, because they won't really help the patient, and they will eventually begin to cause more problems than they're worth. Antidepressants of various types are helpful for mood and for pain. And then the painkillers of the antineuralgia type, like pregabalin, are also useful for some pain. I suppose I'll illustrate my simple strategy for dealing with a patient with fibromyalgia, and that can be tweaked obviously, and it's different for different patients, but this is a simple strategy where you start off using amitriptyline, a very old, very cheap and very flexible antidepressant tricyclic. which has beneficial effects on pain. And at this dose, that's what we're looking at. But I target, and I give that as a target, we're trying to get you to sleep better. So I want you to, this is why you're getting the amitriptyline, to try and help sleep, and escalate it weekly from 10 milligrams, which is a very low dose, up 20, 30, 40. And sometimes at quite a low dose, the patients will get the target better night's sleep. And I expect when the sleep has improved, there will be an impact on pain. And with pain and sleep improved, there will be an impact on activity and on the patient's physical function. And that in turn feeds on itself. Use paracetamol and tramadol, again with the expectation to partly relieve the pain, to reduce its severity. Ask the patient to walk, and if they start off with a 10 minutes walking tolerance, to say after 10 minutes I get too tired, I can't go any further, well then start below that, start at 7 or 8 minutes. Find a lamppost that is 7 or 8 minutes away and walk to that, and do that 3 times a day. And then every 2, 3 or 4 weeks increase by 3, 4, 5 minute increments the duration of the walk, with a target of maybe getting up to 30 minutes 3 times a day, which is a good hour and a half walking a day, which will give you a fairly healthy patient, or a patient who is fit, may have a lot of symptoms, but is tolerating them. And then the other drugs I've talked about, review them frequently so that you're not putting one set of medicines on another. In the management, I would recommend using the Fibromyalgia Symptom Impact Questionnaire for 2 reasons. First of all, because it gives you a good read of the patient's symptoms, but it also allows the patients to see what you expect, and that it's not surprising that they have these various difficulties. So, difficulty brushing the hair, walking continuously for 20 minutes, preparing a homemade meal, vacuum, carrying bags of groceries, climbing stairs, changing bed sheets, sitting in a chair. And all of these are scored from 0 up to 10. That they could accomplish their goals, and that they're aware of the goals they have and they can accomplish them, were overwhelmed by symptoms. And then on the other page, there are questions to do with pain, energy, stiffness, early morning awakening, memory, stress or anxiety, their achiness, coordination or balance, and environmental sensitivities like noise, lights and odors, etc. So these, and then there's there is information on how to tabulate the score. It is less important, I think, than the patient actually seeing seeing the questions and seeing the impacts that you expect, and seeing what you expect to improve. So that's fibromyalgia, a complex disease, a disease with many facets, a disease in which communication with the patient and education of the patient is important in, first of all, getting the diagnosis, and then in finding ways of managing and treating the disease. You can click on any one of these 3 titles to get you to the video related to those titles.